Okay, so hello everyone. Welcome back to this our platform again. Welcome back to Surgical Fix for the second year. Again, we're starting. For this year, we're having new topics, new sessions that will be delivered across the week in various forms. And our Surgical Fix this year will be delivered every Sunday. Instead of 2 sessions a week, we'll be having 1 session. And we are excited to welcome back one of our lecturers from last year, Dr. Ivor-lewis, who will be talking about esophageal cancer for our first topic of the series. So Dr. Ivor-lewis is a thoracic surgery consultant working in Chest Disease Hospital. He is a graduate from Canadian Thoracic Surgery Board, and he has a fellowship in minimal invasive surgery. We are always pleased to work with you, to have you on our platform, and it's a pleasure to have you with us today.
Thank you very much, Ali. First of all, كل عام وانتم بخير ومبارك عليكم بعد الشهر وتقبل طاعتكم. Second of all, I would like to thank you for giving me this opportunity again to be part of this great project, to be honest. So my topic today, I'll be honored to present it to you guys. It's esophageal cancer and what is important in esophageal cancer, meaning that I'm going to highlight a few stuff that's going to be really helpful for your career and for your exam. So let's start with esophageal cancer. For beginning, as a beginning, basically, sorry. All right. For starter, esophageal cancer is very bad disease. It's actually a terrible disease, and it's considered number 6 in mortality. There may be a cure for esophageal cancer, but the problem is that even the cure sometimes is lethal and affects the quality of life. Of course, it affects men more than women. We all know that it has 2 types of esophageal cancer. We have squamous cell carcinoma and adenocarcinoma. Squamous cell carcinoma usually affects any parts of the esophagus, but mostly in the upper half, whereas adenocarcinoma, it affects mostly the GE junction and the lower half of the esophagus. And of course, we cannot start any topic unless we have a bit of anatomical review. So the esophagus starts from C7 down to T11. We have 3 parts and 3 narrowings. The 3 parts is cervical, thoracic, and abdominal. And the 3 narrowings, the first narrowing is at the level of lower esophageal sphincter in the neck, and the second, the upper one, and the second narrowing is in the thoracic cavity at the level where the aorta is crossing the esophagus, and the third narrowing is going to be at the level of the lower esophageal sphincter and the abdomen. Why their narrowings are important? Because it may be the site of ulcers, maybe the site of foreign body impaction, and so on. The blood supply of the esophagus in the neck is supplied by the inferior thyroid artery and drained into the inferior thyroid vein. And the chest, the blood supply is directly from the bronchial arteries and aorta sometimes, and it drains into the azygos and hemiazygos. And the abdomen, the artery is mainly from the left gastric and inferior phrenic artery. One important piece of information that you have to remember if you want to operate on the esophagus is that lymphatic drainage. Lymphatic drainage is longitudinal, meaning that it drains upward towards the head. It's called Kefeld draining. And this is very important because if you want to cut for margin in the esophagus, you should go as high as possible. And of course, the other lymphatic drainage in the abdomen, maybe the chest, maybe trachobronchial lymph nodes, and the abdomen is gastric and celiac. But again, lymphatics is going to be Kefeld in the longitudinal fashion. As for epidemiology, every year we have almost 19,000 or 20,000 new cases. Out of those, we have probably 15,000 deaths. Still in the West is the 7th or 8th most common cancer in males. And overall, the 5-year survival is almost at 20%, between 19 to 20%. Now, mind you, we have a change in the epidemiology of esophageal cancer. In the early 1970s, it used to be the predominant, used to be squamous cell carcinoma, especially in the West, and mainly affected thoracic part and affected Black people. Whereas in at the beginning of 1990s, with a change of the lifestyle and change of dieting, increased the incidence of GERD, adenocarcinoma came into play and affect mostly white people. However, international statistics more or less probably the same. It's still the 9th common esophageal cancer, 9th common cancer. It's still the 6th cause of death, and squamous cell carcinoma is still most common cancer worldwide. Mainly affects the hot area, which is the most in the red area. Affects the southern and eastern Africa, eastern of Asia, Iran, Russia. Those are called the esophageal belt, esophageal cancer belt. We don't know why, but we think that most probably is due to the intake, the poor vegetable intake and fruit intake, in addition to the increase in hot beverages and hot liquids ingestions. We still have men more than women. The ratio is 4-to-1, and the recent reports actually it affects nowadays between 40s and 60s. Before, a few years back, is between 60s and 70s of age, but now it's actually coming down. We have younger patients, we have more healthy patients. That's why we have to understand the esophageal cancer probably much better, and to understand how we approach it in the best way to help those young healthy patients otherwise. Let's move on to the etiology of esophageal cancer. So smoking is actually a risk for both squamous cell carcinoma and adenocarcinoma. But in squamous cell carcinoma, smoking and ethanol ingestions, not any ethanol, it's called not like, wine, red wine or white wine. It should be like a hard ethanol, like in, for example, vodka or tequila, something like that. So the more you ingest alcohol with the smoking, the relative risk of getting esophageal cancer is going to be even worse and more. The other thing is the diet. Of course, if you have diet with nitrosamine or aflatoxin, more red meat, low fruits and low vegetables, that's going to contribute in also squamous cell carcinoma. Other factors may cause squamous cell carcinoma: caustic strictures, ingestion of caustic materials, and probably a latency period of 15 to 20 years. Most likely they're going to have squamous cell carcinoma. Patients with achalasia, the same thing. Hot liquid ingestion more than 65. People who like to drink a lot of coffees and teas at 100 degrees of temperature, they have a 5 times risk of developing a squamous cell carcinoma. Other than this, we have symptoms or syndromes like Plummer-Vinson or Zollinger-Ellison's with increased acidity may actually be a contributor factor to squamous cell carcinoma. In addition to some of the infections has been isolated from probably many reports. One of the reports isolated HPV virus in about 4,000 cases. But we don't know the proper association or the pathophysiology behind it. But definitely they have been associated with squamous cell carcinoma. There's a special condition I've seen personally a few times, patients with tylosis, which is an autosomal dominant condition in which there is a hyperkeratosis in the palms and the plantar aspects. Those people, mostly probably 90% of the cases, they will get squamous cell carcinoma by the age of 70. That's why they do a screening endoscopy by the age of 20. On the other hand, we have the adenocarcinoma. The risk factor or the etiology number one is GERD, the reflux disease, reflux of acid or bile, the same thing. People with symptomatic GERD, 15% of them will have a Barrett's esophagus, and the risk of adenocarcinoma and Barrett's esophagus increases 30 to 60 times more than normal population. And of course, if the Barrett's esophagus has some sort of dysplasia in it, low-grade dysplasia, for example, the annual risk of developing adenocarcinoma is going to be between 4 to 5 per thousand. And if we have a high-grade dysplasia, your chances of getting adenocarcinoma is probably 7% per year. There has been an association between cholecystectomy and adenocarcinoma. We think that if you remove your gallbladder, there will be an increase in production or increase in reflux of bile acid into the esophagus, which work as acid and affect the esophagus like acid reflux, and eventually going to have an adenocarcinoma. The other etiology that we are really we live it on daily basis is going to be the obesity. The more obese, the more risk of getting adenocarcinoma. And the process behind it is we have two types of process. We have mechanical and inflammatory process. The mechanical process is when you have a central, especially the central fat around the abdomen and the fat inside the abdomen, there will be an increase in intragastric pressure, which leads eventually to GERD, disruption of the sphincteric function, lower esophageal sphincter, which eventually lead to GERD. And those people, most of them, or a lot of them, they have some sort of hiatal hernia, which again is going to lead to GERD and adenocarcinoma. The inflammatory process with fat people, they will secrete a lot of cytokines from the fat cells, and eventually this cytokines will lead to some sort of metabolic syndromes like diabetes, blood pressure, hyperlipidemia, and one of the side effects of it is esophageal cancer. And we'll talk about it shortly. So this graph shows simply the more obese the patient is, actually the more chance of getting GERD, eventually adenocarcinoma. So the pathophysiology behind squamous cell carcinoma is when you have an alcohol and smoking together, they work synergistically. They work together. So alcohol will inhibit the detoxification and promote oxidation, which releases a lot of free radicals, which basically prepare the environment of the tobacco carcinogens to penetrate easily in the intracellular and eventually lead to inflammation, dysplasia, and carcinoma in situ. Adenocarcinoma, on the other hand, is when we have GERD. GERD will lead to Barrett's esophagus. We need to know what is Barrett's esophagus. So simply, the Barrett's esophagus is defined as a metaplasia. That means transformation of stratified squamous epithelium into columnar epithelium. Not any columnar epithelium, could be gastric, could be intestinal, but we are interested in the intestinal type with goblet cell, and usually affect the lateral, the distal part of the esophagus. So metaplasia is you have an intestinal type of the columnar epithelium with goblet cells. Okay, the goblet cells are the white vacuoles there. We all know that Barrett's esophagus, it comes with age. Probably it needs 15 to 20 years of symptomatic GERD, affects more male than females. And in Barrett's esophagus, there will be a mutation in TP53 suppressor genes and alteration in P16 and cell cycle apoptosis, which lead eventually to adenocarcinoma. The obesity, as we spoke earlier, that the central fat obese patient, they have an hypertrophied adipocyte. This hypertrophied adipocyte will have some sort of low-grade chronic inflammatory process going inside, and releases a lot of cytokines. Eventually, those cytokines will lead to tumor growth and transformation. So how do they present? Esophageal cancer patients, most of them, the most common symptoms going to be dysphagia. And the dysphagia is characterized to be a progressive. Once they reach to the level of progressive dysphagia, that means that the lumen is going to be between 10 to 13 millimeter in diameter. And of course, if you have dysphagia, they will have, some of them will have, or 50% of them, they will have a weight loss. Some of the signs and symptoms they presented with, that means that the disease is most probably going to be advanced, and you should palliate those patients rather than try to treat them for a cure. One of those symptoms is hoarseness of voice. So hoarseness of voice, when they present in cancer, that means there is a recurrent laryngeal nerve invasion, which indicates that this disease is a little bit advanced. Now, if the tumor was in the mid-esophagus or upper esophagus, there's a chance to involve the bronchus. So they will have some sort of respiratory symptoms, aspiration, and eventually there will be some sort of invasion into the bronchial tree or tracheal tree, which that means that the problem is severe and is advanced. Examination-wise, most of them, they have normal examination, unless it's so advanced that the lymph nodes in the neck and supraclavicular, the Burkitt's nodes, are involved. Then you will palpate them or you'll feel them. Again, if you have a metastasis to the liver, then you might have a hepatomegaly on abdominal examination. Once you have a patient with dysphagia, you should raise a flag of red flag that this patient might have esophageal cancer, but put on your mind that it might be something else. So your differential diagnosis is going to be achalasia or pseudoachalasia, benign strictures, benign tumors, or even gastric cancer. So once you met with the patient and you think that the patient is having a sign and symptoms of esophageal cancer, then you have to work him up. So the workup list this is my list. Endoscopy, which I think endoscopy and biopsy is very important, it's crucial for diagnosis. And I include also CT scan, PET scan, endoscopic ultrasound, barium solo, and bronchoscopy. So CT scan, I think, is a very important tool. It tells me a lot about the tumor. It tells me whether the tumor is invading the adjacent structure or not. Or sometimes it gives me an idea about the lymph nodes surrounding the esophagus and the chest and the abdomen. PET scan also is very important nowadays. We use it for, of course, staging the cancer by looking for lymph node metastasis and distal or distant organ metastasis. PET scan sometimes reflects the behavior and prognosis of the esophageal cancer. I will talk about it shortly. One of the tools that has been that has proven its importance is endoscopic ultrasound. Endoscopic ultrasound is very sensitive to assess the depth of the tumor inside the wall and the lymph nodes. So when they introduce the ultrasound, they look for lymph nodes. They have special characteristics. The size of it, whether it's homogeneous or heterogeneous, whether it's well circumscribed or not. So once they evaluate, once they see the lymph nodes in the endoscopic ultrasound, then they can basically confirm the metastasis by needle biopsy. So endoscopic ultrasound and needle biopsy is more sensitive than CT scan. We have one of the reports, for example, if you added EUS and FNA compared to CT scan, the sensitivity probably 83% versus 29%. I mean, it's obviously much better than CT scan alone. So endoscopic ultrasound, it's excellent for differentiation between T1, the depth of the tumor between T1 and T2 versus T3 and T4, but they are not very good in differentiating between the subcategory, for example, T1A versus T1B, or T1 versus T2, okay? But we really like to use the endoscopic ultrasound to give us an excellent idea and excellent information about the tumor depth and lymph node involvement. So if you have patients with mid-esophagus or upper esophageal tumor, then I'm usually concerned about whether the trachea is involved or not involved. So what we do bronchoscopy. So bronchoscopy is very important also to assess whether there is an invasion or there is no invasion in the trachea. Last but not least is barium swallow. Barium swallow, when I use it, I don't use it for staging or diagnosis, but it gives me a roadmap for my or plan for my next step, which could be surgery. So we have to know what are the signs we are looking for when we do barium swallow. So esophageal cancer in barium swallow, they should have strictures. The stricture should be like an apple core stricture. When you have a stricture, there will be a pre-stricture dilatation of the esophagus, and we have something called shouldering of the tumor. And if you did a flow of the barium swallow, if you watch the flow of the barium swallow, the flow will be turbulent rather than smooth flow in wide open esophagus. So again, barium swallow is not for staging; it's just for mapping the tumor and whether you will basically assess whether the lumen is accessible by endoscopy or not. Once we finish from our workup of the patient, then we put them in a stage, and the staging we use is a TNM stage, the 8th edition. The T stands for size, N for lymph nodes, M for metastasis, and the importance of assessing the T or the size is actually when we have the tumor is deep enough, that means that there's a chance or there's a risk of metastasizing or involving the lymph nodes. So, for example, in this table here, if we have, for example, here TIS-M1, that means the tumor is involving the epithelium to the lamina propria, but not involving the lamina propria. Then the chances of getting lymph nodes involved is going to be almost zero. But if you take it, if the tumor is deep, for example, in SM3, T1B, SM3, that means it's involving deep into the submucosa, then the chances of lymph nodes or the risk of lymph node involvement is going to reach up to almost 46%. That's why it's very important to assess the depth and very important to know whether there is a lymph node involvement or not. There are certain procedure we use nowadays is very important procedure. I think it's going to help. We have only 1 or 2 devices here in Kuwait, which is upper endoscopy with endoscopic resection capability. So for starter, upper GI endoscopy is a very important tool, as we explained, for biopsy and for confirmation. Sometimes upper GI endoscopy also it gives us an idea about the survival. So if the tumor, for example, is less than 2 centimeters, they have very good survival. But if it's more than 2 centimeters, that means the disease probably is bulky and advanced. So the survival rate of the survival is going to go down. The other tool that we are using with endoscopy is called, nowadays it's called an endoscopic resection, either endoscopic mucosal resection or endoscopic submucosal resection. Endoscopic resection is done by regular GI, upper GI endoscopy. We inject normal saline in the below the lesion, elevating the lesion away from the wall, and then using suction cup with a special knife, we cut all the lesion from the wall of the esophagus and pin it on a board and send it for the pathologist. The pathologist will read it carefully and will tell us whether the margins are involved, or whether they tell us the depth of the lesion, the differentiation of the lesion, and whether there is a lymphovascular invasion or not. This technique or this procedure may be a cure. You may be curing the patient without doing a total esophagectomy. If you have removed all the tumor, all the lesion, and or if the submucosa is not involved and well-differentiated lesion, clear margins, no lymphovascular invasion, then you basically cure the patient. What you have to do is just, probably you follow up the patient for the next 10 years or so. The endoscopic resection of that lesion, it shouldn't be for any lesion. It should be for mainly for T1A, T1B, or nodular lesion less than 2 centimeters. This is at least is very important to put it in your mind and think of an option of treatment if you have patients with early stage lung cancer. So what we're looking for histologically in squamous cell carcinoma, when they look at it, they look for keratinocyte, and in Barrett's, in adenocarcinoma, they look histologically for Barrett's changes, and once they get the Barrett's, they will assess the dysplasia to see the amount of differentiation, whether it's well differentiated or undifferentiated. It's very important to understand this, and very important to know what the differentiation of the tumor, because it's going to affect the survival rate and affect the prognosis. So the Society of Thoracic Surgery, they posted their recommendation for working up the patients. They stated that endoscopy is probably the cornerstone for diagnosis and biopsy, and the list we mentioned earlier, but they recommended that EMR, endoscopic mucosal resection, should be considered as diagnostic and staging tool if you have a small nodule less than 2 centimeters and with dysplasia, of course. If you have a patient with T3 and T4 adenocarcinoma or Siewert 3, we're gonna talk about Siewert classification, then which is locally advanced, then I think you should do a laparoscopic staging to make sure that there is no peritoneal metastasis. Prognosis is stage related. If you have an early stage, then your survival may be like 5-year survival may reach to 100%, especially in 0. But if you have a later stage, then your survival, 5-year survival, is going to be almost 0. Okay, so overall survival is going to be 20%, but there are a subgroup that had, or they underwent surgery, total esophagectomy. This subgroup had initially neoadjuvant therapy, chemotherapy, and radiotherapy. This particular subgroup actually had a survival rate up to 50%, and that's why we should consider, we should know which one will give them a neoadjuvant chemotherapy and which one we should not give them neoadjuvant, should have basically a surgical resection or definitive chemoradiotherapy. We explained earlier that PET scan may be an indicator for survival. Actually, the more the SUV uptake on PET scan, that means that the tumor is aggressive and the survival would be low. Biopsying the lesion and study the mutation or expression of HER2 disease actually associated with, again, poor survival. The survival will come down to 12% to 14%. For you guys, the treatment, the gold standard treatment for esophageal cancer is esophagectomy. Okay, this is the bottom line. But what about NCCN? NCCN, they recommended different ways. If you have the facility of doing endoscopic resection or therapy, then you should put it in your plan. So NCCN approach is that you can do endoscopic therapy for high-grade dysplasia or T1A or T1B or tumor less than 2 centimeters. Those lesions, you can easily approach them by doing just endoscopic resection or endoscopic mucosal or submucosal resection. And you should consider esophagectomy if you have extensive high-grade dysplasia or if the tumor is more than T1B, of course. All right, this is their approach. But what about if you have actually squamous cell carcinoma or adenocarcinoma? When should we give a pre-op chemoradiotherapy and when we should not? For squamous cell carcinoma, it is recommended to do a pre-op chemoradiotherapy if you have T1B, lymph node positive, or locally advanced disease. Then always consider pre-op chemoradiotherapy. Patients with squamous cell carcinoma in the neck, there is no surgery for them. They go for definitive chemoradiotherapy, and the response is excellent with that. In adenocarcinoma, if you have T1B and positive lymph node involvement or locally advanced, again, always consider pre-op chemoradiotherapy. The NCCN also, they thought that if you have adenocarcinoma less than 2 centimeters in a young healthy patient with well differentiation, they were happy to take the patient to the surgery right away without doing pre-op chemo and radiotherapy. Okay, this is for pre-op treatment. Post-op treatment, their approach that if you have squamous cell carcinoma with R0 resection, then you don't have to do any post-op chemotherapy or radiotherapy. Whereas in adenocarcinoma, regardless of type of resection, R0, R1, or R2, all those patients, they should have a post-op chemo and radiotherapy for improving the survival. Okay, and of course, if you have a tumor that they are not resectable, then those patients, they should right away go for definitive chemo or radiotherapy without surgery. So what are the surgical indications and contraindications? Indication for esophagectomy is if you have esophageal cancer candidate for surgery, then this is an indication. Or patient that with high-grade dysphagia, for example, and a Barrett's that you cannot control with endoscopic resection, then take those patients for surgery. Esophagectomy is contraindicated in patients with N2 disease or distant metastasis, or probably invasion of adjacent structure, or patients that cannot tolerate surgery with poor lung function and poor cardiac function. So esophagectomy is the cornerstone of the treatment, is the main treatment for esophageal cancer. It's very critical in multidisciplinary treatment, okay? Why is that? That's why I told you guys, you should consider esophagectomy as the gold standard, because endoscopic mucosal resection is still experimental to certain and limited to certain centers. For example, here we have it only in one center or two centers, that's it. And I'm sure there are a lot of countries that don't even have it, and I don't think they're going to be really easy to get it and do the procedure. The other thing for esophagectomies, nowadays we don't use a palliative resection. Before, in the older days, we do esophagectomies for palliation, just to restore the feeding process. Many types of esophagectomies, all the types of esophagectomies, there are no survival differences. The only thing that affects prognosis is going to be the stage of the tumor, not the type of surgery. Okay. Before we commit ourselves to do an extensive and a major surgery like esophagectomy, we have to make sure that we're actually dealing with esophageal cancer. Hence, Siewert classification came into the play. So Siewert classified the tumors at the GE junction into 3 classifications. The first classification, Siewert 1, is when you have a tumor between 1 to 5 centimeters away from the proper cardia, anatomical cardia. Siewert 2 is within 1 centimeter, 1 to 2 centimeters distal to the cardia, whereas Siewert 3 is actually between 2 to 5 centimeters distal to the cardia. So why I'm saying this? Because the approach is going to be different. In Siewert 1 and Siewert 2, we consider those tumors as a proper esophageal cancer. So the treatment is going to be esophagectomy, whereas in Siewert 3, it's considered a proper gastric cancer. So the treatment here is going to be total gastrectomy. Okay, so that's why you have to decide, especially the GE junction tumors, we have to decide whether it's a Siewert 1, Siewert 2, or Siewert 3. So then we can plan our surgery, or we plan the perfect surgery for the patients. As I mentioned earlier, we have many types of esophagectomies. One of the types we're using is transthoracic resection. They are categorized into 2: Ivor-lewis surgeries or approach, or McEwen approach. In Ivor-lewis, which is 2-hole technique, we use laparotomy and dry thoracotomy. In McEwen, it's called the 3-hole technique, which involves dry thoracotomy, laparotomy, and the anastomosis is going to be in the neck left side. Whereas in Ivor-lewis, the anastomosis is in the left side of the chest, the right side of the chest. So how do we approach? First of all, we in Ivor-lewis, for example, we open the abdomen, we explore the peritoneum, mobilizing the stomach. Now you have to pay attention. In mobilizing the stomach, you should preserve the right gastric and right gastroepifluid vessel. Right gastric and right gastroepifluid vessels. It's just opposite to the sleeve gastrectomy. Okay. So once we preserve those vessels, then we mobilize the GE junction and enlarge the hiatus. And then before we fashion the conduit, either you do a drainage procedure like pylotomy or pyloromyotomy, or just leave it. Myself, I don't do anything basically. I just leave it. Sometimes I inject Botox in the pylorus, so acting as a drainage procedure. And then before you close the abdomen, make sure that you put a feeding jejunostomy. It's very important. After this, the patients will be repositioned into the left lateral position. The right side should be up. We open the right side, the 5th intercostal space. Once we are inside the chest, we identify the inferior pulmonary ligament and mobilize the inferior pulmonary ligament. Just below the inferior pulmonary ligament, you will identify the esophagus. Then encircle the esophagus, mobilize it, and pull the stomach inside the esophagus. And then you can do the fashioning of the conduit and do anastomosis in the chest. This is basically the Ivor-lewis. Whereas the McEwen with 3 holes, we start in the chest first, and then we position the patient supine, open the abdomen, and open the left side of the neck, so that the anastomosis will be in the neck, by delivering the stomach in the posterior mediastinum up to the neck, where the second team will be there, and they will start anastomosing the stomach with the esophagus. Again, I cannot emphasize more on the importance of preserving the right the right gastrofluid and the right gastric, because your conduit, your stomach conduit, will be depending solely on those arteries. Okay, you can sacrifice other arteries, but not the right gastric fluid or the right gastric. So what are the possible conduits we use in esophagectomy? The possible conduit, the best conduit is going to be stomach. Why? Because it's single anastomosis and they have a very good blood supply. What other options we have? We have colon, either right or sigmoid. I like the sigmoid. Or we can use jejunum in case if we don't have sigmoid, if we don't have like a colon, then you can use jejunum as a free flap. So Ivor-lewis on the left side, we start with the abdomen, and this is the shape of the conduit. The anastomosis will be in the chest, whereas McEwen, we start with the chest first, mobilize the stomach, mobilize the esophagus, and then the anastomosis will be in the chest and left-sided anastomosis, of the esophagus. The second type of surgery is called transhiatal. Transhiatal, again, is two-hole technique. The patient is supine. We don't open the chest, okay? What we do is just prepare the neck and prepare the abdomen, open the abdomen, mobilize the stomach the same way as we described, preserving the right gastric fluid and the right gastric, and then deliver the conduit through the posterior mediastinum into the neck, where the second team will have it and start anastomosis as soon as possible. Of course, before you leave the chest after esophagectomy, before you leave the patient after esophagectomy, make sure that you leave drains in the neck. You don't have to leave drains in the abdomen, but if you open the chest, of course, you have to leave the chest tube. Of course, nowadays, what we do is we do minimal invasive surgery, many techniques for esophagectomy. The minimal invasive surgery for esophagectomy, the advantage of it, of course, shorter hospital stay, less pain, faster recovery, but the survival is going to be the same as open technique, sometimes with less complication and less hospital stay. At the end of the procedure, that's what you have to understand. At the end of the procedure, you're going to have something like this. This is the specimen. The tumor is in the middle. Your margin is going to be 5 centimeters away from the tumor, now on the lateral side, distally, and at least 10 centimeters proximally along the esophagus. Why? Because we explained earlier that there is a longitudinal drainage of the lymphatics. Okay, the more you go up, the better the margins will be. So after the surgery, what are the post-op care? What can we do for them? Those patients usually extubated in the operating room, and we send the patient to the ICU for 1 night or so, and there's no complication. We send them to the ward the day after. Usually we start feeding jejunostomy from the first day, and we keep the patient fasting on antibiotics, on PPIs, and by day 6, we send them for barium swallow just to make sure that there is no leak and no stenosis, or there is no leak. If there is nothing like this, we start feeding them gradually by clear fluids and advance them every day or every 2 days. The possible complication, most of the complications from total esophagectomy coming from the chest and coming from the heart, the cardiac. So 40% are respiratory, cardiac, and sepsis. 20% respiratory, cardiac arrhythmias. Respiratory is usually pneumonia or atelectasis. Cardiac, as we said, arrhythmias. The sepsis are from the leak. You're worried about the anastomotic leak in the neck or anastomotic leak in the chest. And in the long run, sometimes you will get some strictures from your anastomosis. But I would like to mention that the leak in the chest is probably lower than the leak from the neck anastomosis. But the problem is that the leak in the chest carries a lot of morbidities because they're going to develop pyema, adhesions, pneumonias, etc. But the leak in the neck, you can simply deal with it bedside by just opening the neck and just pack it with antibiotics and feeding jejunostomy, of course, where you feed the patients. In order to decrease the complication, in order to minimize the complication rate, those patients should be operated on high volume center. Okay, with a high volume center, the mortality will improve mostly because of the team approach. They have better intensivists, they have better probably surgeons, and better team approach nurses and stuff like that, because they know the possible complications and they deal with the patient, esophagectomy patients, most of the time. Okay, so what we do in Kuwait, how we approach esophageal cancer here in Kuwait. We get the referral from everybody. We get the referral from gastroenterologists, we get the referral from surgeons, we get referral also from physicians, internal medicine. So once we get the referral, we review all the investigations and make sure they are complete, i.e. endoscopy is there, biopsy is there, ultrasound, endoscopic ultrasound, CT scan, PET scan, barium swallow, and then I usually discuss with the referral doctor, especially if the doctor was a gastroenterologist, and assess the sense of the tumor, whether the tumor is long, is short, whether the tumor is obstructing or non-obstructing. So I will decide then whether I need to go and do my own endoscopy before surgery or not. I usually do my own endoscopy on table. Sometimes I discuss the tumor, discuss the patient in tumor board, and will come into the plan whether the patient needs needs a pre-op chemo radiotherapy or not. If you are worried or if you are not sure about your specimen, the biopsy, histology, then just be comfortable and be relaxed and just send the patient for second opinion or second pathology. This pathologist the second pathologist should be experienced and should be a gastroenterology pathologist. The reason is you want to confirm whether the patient has high-grade dysplasia or not, or whether the patient has actually adenocarcinoma or squamous cell carcinoma or not. Once we agreed for surgery, this patient, our approach will be a minimal invasive approach. We do something called a modified McEwen. So we approach the tumor, the esophagus from the chest first by VATS, a uniportal approach, uniportal VATS. We mobilize the whole esophagus and we remove the lymph nodes associated with the esophagus or close to the esophagus. Then we leave a chest tube in, and then we flip the patient into supine position, prepare the neck, and prepare the abdomen. And the abdomen, what we do is laparoscopic gastric mobilization, preserving again the right gastric and gastroepifluic. Sometimes what we do, I fashion the conduit inside the abdomen, or sometimes I do a mini laparotomy, like 4 centimeters at the upper abdomen, and do an extracorporeal conduit fashioning. After that, I deliver the conduit inside the posterior mediastinum into the neck, where my second team will be ready to receive the specimen and perform the neck anastomosis. Here again, the margins will be at least 5 centimeters distal and 10 centimeters proximal. Before I close the abdomen, we do feeding jejunostomy. I don't leave drains in the abdomen. Okay, so in the neck, the anastomosis is hybrid technique. We use hybrid technique. The posterior wall is usually anastomosed by stapler, whereas the anterior wall of the esophagus is anastomosed by interrupted sutures. Okay, that's how we approach it in the in our hospital, and our outcome, alhamdulillah, is very good outcome. People usually they leave within a week or so. So what about chemo and radiotherapy? Pre-op chemo and radiotherapy is beneficial and has been proven. Okay, post-op chemo and radiotherapy alone, I mean after the surgery, there is never shown any survival benefit. Why pre-op is important? Because it decreases the bulk of the tumor. It actually increases the curative resection, and it delays or eliminates the distant metastasis. However, this is chemo and radiotherapy. However, the chemotherapy alone, it's still controversial. Initially, I used this technique, or I used this approach, but nowadays I found the chemoradiotherapy approach is probably more beneficial, of course, for the patient. And this is based on a cross trial, which showed a huge benefit from the multidisciplinary approach or multi-team approach. That means we do Chemo Rad surgery and followed by Chemo Rad. The benefit has been shown. The survival rate increased from 24 months to almost 50 months. That's double up. And the recurrence is much lower than surgery alone. So they use cisplatin 5-FU and 45 gray of radiation. And after that, we wait for a month or so to do the surgery. If you have a complete response, definitely your survival will be better. And if there's a partial response, the survival will decrease a little bit. Recently, they added immunotherapy, especially for locally advanced squamous cell carcinoma. And we are so far waiting for the results. I'm really enthusiastic to use this drug for adjuvant therapy, of course. Okay, so we finished from the curative resection. What about palliative care? What do you want to do for patients with tumor that you cannot resect? So the idea behind the palliative care is to control the dysphagia and to improve the quality of life. So there are many techniques to ensure a lumen restoration. So you're allowing the patient to drink and eat normally. You can use an endoscopic technique. You can use radiotherapy, chemotherapy, or to improve quality of life. Sometimes you use we do feeding jejunostomy. Stents are used to restore the lumen. Radiotherapy, especially brachytherapy, also used to restore the lumen. Sometimes we use both techniques, radiotherapy and stent together. Chemotherapy is also used for palliative to improve the quality of life. Again, there is an endoscopic technique by utilizing laser or photodynamic therapy to restore the lumen and allow the patient to drink and eat normally. The relief is like amazing relief. Symptomatic relief is about 30%. So I guess that's it for now. Thank you very much. Ali?
Thank you, Dr. Darar, for the amazing lecture. Would you like to take? We have some questions in the Q&A. If you want to have a look.
You can put them, or shall I put them?
I can read them for you if you want.
Yeah, sure.
We have a question from Zainab for workup. What is the initial investigations? I think you covered them. If you want to go over them again.
Well, Zainab, thank you for this question. Actually, I just want to mention something that the workup, with workup, we initiate both the staging and diagnosis of the esophageal cancer in parallel. Okay, so for example, we do a CT scan for both staging and for diagnosis. So most of the time, patients come with different investigation, either with endoscopy alone or with CT scan alone, and we have to follow all the other investigations. So when patient comes to you with possible esophageal cancer, I mean, patient is dysphagic, then the first thing to do is, of course, you do endoscopy and biopsy. Okay. After that, you do the others. If you diagnose the tumor in the esophagus by endoscopy, you took a biopsy, you found a tumor in the esophagus, then you have to do a CT scan, EUS, sometimes bronchoscopy according to the location of the tumor, and PET scan. Okay, so there is no one before the other one, and I think you have to make sure, first of all, that the patient is having esophageal cancer. In my opinion, endoscopy is probably the most important test.
Perfect. How about we go over the MCQs first, and then we'll come back to the Q&A. Is that okay?
Sure. Yeah, sure. Go ahead. You want to read?
So the first MCQ will be the most common risk factors for squamous cell carcinomas are, and we have first option: alcohol, smoking, GERD, obesity, alcohol, and smoking. We'll be putting up the polls, and everyone can answer in the poll. We'll give them a few seconds to answer. Okay, so we have about 60% of the audience answered. We'll be sharing the result.
Great. Oh my God. Excellent. Well done. I'm doing something good here. Excellent. That's really good. Yeah, this is the correct answer. Remember, alcohol and smoking in squamous cell carcinoma, they work synergistically. Alcohol prepare the ground, and smoking will kill it. Okay? Excellent. Well done.
Perfect. So you can go ahead on the next question, Doctor.
Sure. All right, it's not moving. All right.
So you can go ahead with the question, Victor.
So the second question is, most common presentation of esophageal cancer is cough, chest pain, weight loss, progressive dysphagia, all of the above.
Okay, so we'll
Cough,
be
chest pain, weight loss, progressive dysphagia, and all of the above.
we'll give them a few seconds to answer.
No problem.
So we're sharing the results now.
Oh God, beautiful. Yeah, well done, guys. Well done. That's correct. The correct answer is progressive dysphagia. Okay, and once they get dysphagia, that means the lumen of the esophagus is going to be about 13 millimeter or 10 millimeter in diameter. That's correct. Well done. Well done.
So
take the third question.
yes, please.
All right. So the third question, all investigations are essential in diagnosis of lower esophageal adenocarcinoma, except PET scan, CT scan, endoscopy, biopsy, bronchoscopy, EUS. Diagnosis of lower esophageal adenocarcinoma. PET scan, CT scan, endoscopy and biopsy, bronchoscopy, and endoscopic ultrasound. Which one is not essential?
Last few seconds, put your answers in. And we're gonna share the results.
Yeah, that's even better. Well done. Excellent. أنا حكوا بس أنا دايخ. لا أنتم كلكم تمام ما شاء الله عليكم. طلعنا أنا بس دايخ. This is good job. That's correct. The answer is bronchoscopy. Bronchoscopy is not needed for lower esophageal cancer. If you have upper esophageal or mid esophageal cancer, then bronchoscopy is crucial and essential. Otherwise, for lower esophageal adenocarcinoma, bronchoscopy is not needed. Okay, so well done. Excellent. All right. Let's take. All right. Let's take this a little bit long, but you're gonna get it, I'm sure. So I have a 70-year-old female, history of reflux symptoms, underwent upper GI endoscopy and biopsy. The histopathology results came as high-grade dysplasia. So what is next? Will you do endoscopic resection or PET scan or barium swallow or esophagectomy, minimal invasive esophagectomy, or you will ask for second opinion, pathology, second opinion. So you've got a patient with high-grade dysplasia, and your action is going to be endoscopic resection, PET scan, barium swallow, MIS esophagectomy, or second opinion of the pathologist, experienced pathologist. That's going to be tough a little bit.
Let's see how they do in this question.
Yeah. I'm really curious now.
We'll give them a bit longer for this one as it's tougher.
So I told you in the presentation that what I do sometimes, basically, patient referred to me. If I'm not sure, I'm not happy, then I will do something. It's mentioned there.
Last few seconds. And we're going to end the poll.
So
some mixed results here.
It is mixed results, but you know, all right. Maybe I didn't deliver that. Maybe I didn't deliver that message clearly. So I understand the endoscopic resection, and as for PET CT scan, barium swallow, or esophagectomy MIS. Before we do this, actually, we first have to confirm the high-grade dysplasia because the reading is going to be difficult for the pathologist. So what we do is I ask for a second opinion for pathologist from the pathologist, not any pathologist, but pathologist with experience in GI. Okay, they should confirm whether this is a high-grade dysplasia or not. And if there is high-grade dysplasia, they should tell me whether there is a tumor cells inside it or not. Okay, so this is what I do. But doing endoscopic resection is definitely I can understand, and you can use it for diagnosis. Okay, so your answer is not totally wrong. Your answer is probably correct, but before you do endoscopic resection, you have the slides. Before you jeopardizing the patient for the second surgery or second procedure, you have the slides. Just take the slides and go for a specialized or experienced pathologist and tell them if this is correct, if this is high-grade dysplasia or not. Okay, so the answer is 5 second opinions, but I kind of okay with the first one. Okay, so well done.
Perfect. Thank you for the explanation. So, and we'll move on to the next question.
Right. I think last one probably. I don't know.
I think we have 2 more.
Oh, is that right? I wrote them, man. Okay. So the 5th one is a 56-year-old male smoker, recently diagnosed with probably adenocarcinoma, probably T3, Siewert 3. The best course of action. So adenocarcinoma diagnosed, T3, Siewert 3. Is it your best course of action? It's going to be MIS esophagectomy and gastric pull-up, or transhiatal esophagectomy, gastric pull-up, or Ivor-lewis esophagectomy, gastric pull-up, total gastrectomy, Roux-en-Y, or none of the above. So you have a patient with diagnosis, adenocarcinoma, T3, Siewert 3.
1 second. I think we have just one option missing. I'll just add it now. None. And we're sharing the poll now.
So just remember the Siewert classification, ladies and gentlemen. And remember how we approach them. Siewert 1, Siewert 2, and Siewert 3. Right.
A few more seconds. And yes, about 1 minute.
Right. Generous.
So we're going to end the poll.
Good job. Yeah, that's what I'm talking about. So you're right. Total gastrectomy is the answer. Remember Siewert's classification. That's very important. If you have Siewert 1, it's a true esophageal cancer. So the treatment is going to be total esophagectomy and gastric pull-up. Siewert 2, again, is considered as a true esophageal cancer. Okay, and the approach is going to be total esophagectomy and gastric pull-up. Siewert 3 is a true gastric cancer. Okay, or true, GE junction gastric cancer. So those patients should have total gastrectomy rather than esophagectomy. So the answer is 4, and well done, guys. Well done.
Perfect. And we'll have the final question now, I think. Question 6.
Right. So question 6. Right. Should be easy, guys. During esophagectomy, blood vessels to be preserved during gastric mobilization. Left, right gastroepipluic and right gastric artery, short gastric and gastroepipluic, left gastric artery, left gastric and celiac, or short gastric and celiac? Actually, so blood vessel to be reserved or preserved. Remember, reverse to sleeve gastrectomy. We preserve here a vessels, two vessels. Is it right gastrofluic and right gastric, or short gastric and gastropluic, and or left gastric and celiac, or short gastric and celiac?
Okay, and we're gonna end the poll in a few seconds. Okay, and the results are on the screen.
Yes, sure. So what's chasing? That's really good. All right, that's excellent. Remember the scheme I told you, the cartoon. Again, I cannot emphasize more, or cannot emphasize enough that the right gastric, gastropluic, and right gastric arteries are the most important arteries to preserve during mobilization, so that your conduit will totally depend on them. So the answer is 1. Okay. Otherwise, the other vessels you can basically sacrifice, not celiac trunk, but I mean the short gastric and left gastric actually you can sacrifice. Okay. So the answer is 1, and I'm very happy with the results. Excellent.
So I think that's the last MCQ question we have, and we can go ahead to the Q&A. Are you able to see the Q&A panel on your screen?
You can read them if you want.
We don't have many questions, so we have a question from what is the reason of having hepatosplenomegaly in examination? I'm not sure for which part he's referring to.
Yeah, well, I guess it's not hepatospleno, but mainly hepatic or hepatomegaly. The reason behind it is because you want to rule out metastasis, basically. Ruba, thank you for your question.
And then we have a question from Imad. What is the best approach for spasmodic dysphagia for final diagnosis?
Yeah, I don't think this is the proper topic for it. We're talking about esophageal cancer now. Yeah, if you want, I can answer you later. Basically, you can email me or contact me, Imad.
Okay, perfect. And in case if a patient has also peptic ulcer disease, can we use the stomach as a conduit?
Where is that?
That is below Imad's question.
Approach spasmodic. I don't have it here. Okay. So, anyways, it depends really on the site of the peptic ulcer, and of course, we have to investigate whether the peptic ulcer is benign or not benign, or the ulcer is benign or not benign. Peptic ulcer disease will not preclude the the stomach as a conduit for a gastric polyp. So the answer is peptic ulcer disease is not contraindicated, not contraindication to use the stomach for as a conduit. That's a good question. Thank you.
And then we have a question from Wilmer. What is the most conservative treatment post-operatively for a metastatic esophageal cancer, since radiation and chemo is of no survival rate?
So what is the most conservative treatment post-operatively for metastatic? So we're talking about a palliative procedure, if I understand the question correctly. Metastatic esophageal cancer, we palliate the patient, okay? So it depends on what we are palliating. Are we palliating the esophagus, the dysphagia, for example, or we are palliating the pain from metastasis? I guess there are many palliative procedures to restore the lumen of the esophagus. We can use a stent, we can use photodynamic therapy, or sometimes radiofrequency ablation. Those are local treatments of the esophagus. But if you have metastasis elsewhere, I don't think we can use other things rather than radiation and chemotherapy, except sometimes the squamous cell carcinoma with PD-L1 expression, we can use immunotherapy. Okay, that's what I think. Otherwise, radiation and chemotherapy are used for palliation, and of course, with metastatic disease, there is the survival. The survival is very dismal. So maybe there is not a lot of survival, but at least we are improving quality of life somehow. Thank you.
And we have another question from George. He's asking about if there is any comparative studies between cross and float trials for adenocarcinoma of esophageal cancer. I'm assuming.
I'm not really familiar with the float trial. I didn't come across it yet, but I think there is a comparison between cross and MAGIC trial, which is used for stomach cancer.
Mm-hmm.
And in MAGIC, I guess they use only chemotherapy, but in cross they use chemo and radiotherapy. And definitely, the chemo radiotherapy has better benefits than chemotherapy alone, including surgery, of course. So to be honest, I'm not familiar with the float. I didn't come across it yet, but I'll read it soon, inshallah. Thank you.
We have a couple more if you want to have a look at.
Yeah. You're gonna buy me coffee after this. All right, go ahead.
So we'll pick a last question for you. And during hiatus expanding, just before the gastric pull-up, what is the best way to avoid thoracic duct injury?
The best way to avoid them is just ligate them. I don't ligate them, basically. What I do is just, dilate it. There is a way to dilate the hiatus. I don't dilate downward. I dilate like at 10 o'clock from the hiatus. So I'm avoiding the thoracic duct. Okay, so the location of thoracic duct is between the IVC and between the aorta and the esophagus. Okay, I don't go there. What I do is I open the hiatus at 10 o'clock, about 1 or 2 centimeters. Okay, but that's a good question, actually. If you are worried, just ligate it at the hiatus. There is another question here by George. I think this is a good question. Okay. Actually, this question is the last one, I guess, here. So George is asking, what do you do for complete response with neoadjuvant? Okay, this question actually usually I get asked during the tumor board, Ali. So the answer is I remove the esophagus. Complete response, I'll remove the esophagus. The tumor is there. It doesn't mean that's not going to be a recurrence. It has been shown that if you do not remove the esophagus, there will be high recurrence rate. Okay. Complete response with esophagectomy, that means the survival rate will be even better. We're talking about 50 months rather than 24 months. Okay, so that's your answer, George. Thank you very much.
And we'll end with that question. Thank you, Dr. Darar, for your time and effort in putting this wonderful lecture for us today. It's always a pleasure to have you with us on our platform on Surgical Fix. Among other courses, we had you with us. It's been amazing, and the MCQs were exciting to consolidate the information given today. Thank you so much.
Thank you, everybody, and thank you for giving me this opportunity. You guys did a great job, actually, with MCQs. Well done.
Thank you. And I will take this opportunity to announce on behalf of SurgiQuate team, we are excited to introduce a new series, the Surgical Debate, which is the first of its kind in the region. This surgical debate will discuss various topics which are currently debating new treatments and new managements and diseases where are currently being debated around the world. And we are going to start with the first session on Wednesday. The session will start off on how to debate, and will introduce the debate culture to our residents in Kuwait and around the world. The session will be hosted by Dr. Saud Zaid, who is an assistant professor of surgery in Kuwait University and general surgeon, critical care and trauma surgeon consultant. We'll post the link in the chat, and you can feel free to scan the QR codes to register for the next session, or to scan the other QR codes to take you to various areas of our platform. Thank you everyone for attending today. The next session will be, as I mentioned, on the surgical debate on Wednesday, and the next session for the surgical fix will be on inguinal hernia on next Sunday. Please stay tuned on our Instagram and Twitter for our upcoming events and for the next sessions link to register for it. Thank you, everyone. I will leave the QR codes up for a few minutes before we end the session.